stage is yours
Thank you,
now.
sir. Thank you, sir. So, a very good evening to all the attendees who has, sir, is my voice clear, sir?
Yes, your slides are quite visible, very well visible, and
Okay.
you are audible also, Dr. Tapas.
Thank you, sir. Thank you, sir, for
Yeah.
confirming. So, a very good evening to all the attendees who have joined today for the online class of ventilation workshop for IAPNEOCON 2025. So, at the outset, I would like to thank the organizers of IAPNEOCON for inviting me as a faculty for this workshop. I hope this workshop would be a great success. So for today's talk, I'm going to discuss about volume ventilation and hybrid modes of ventilation. So these are my learning objectives. So in next 45 minutes, I'm going to discuss regarding the rationale for volume ventilation, that whether it is volutrauma or it is a barotrauma that is more dangerous. Then basic differences between a volume control ventilation and a pressure control ventilation. So why there is an increasing interest in volume ventilation nowadays. I'm going to talk about the hybrid modes of ventilation. Then I'm going to discuss regarding whether the evidence is now sufficient to switch the practice from pressure control ventilation to volume control ventilation. And at the end, I shall be discussing some of the practical aspects of the volume ventilation. So let's begin with the discussion. So I hope the attendees must have listened to the talk of Dr. Uma Maheshwari yesterday. So to recapitulate that talk, so whenever a mechanical inflation is given, so there are three phase variables that are important. So these are like trigger, limit, and cycle. So what is trigger? So trigger is the parameter which initiates the mechanical breath. So mechanical breath is initiated by trigger, and this trigger is done by the baby. Okay, so it can be the pressure trigger or it can be the flow trigger. Then we have limit. So limit is the variable which determines the gas flow into the lung. So basically, it is like the parameter which guides the uh, delivery of gas into the lung, and it's like it is like a pressure control ventilation or pressure limited ventilation. So when the preset pressure is delivered, the inspiration will end. Similarly, if it is like a volume limited ventilation, so when the preset tidal volume is delivered, the inspiration will end. So this is like limit. And what is cycling? So cycling is like switching from inspiration to expiration. So it can be the flow cycling or it can be the time cycling. So the conventional time cycle pressure limited ventilation, the ventilator delivers a constant preset pressure with each ventilator breath. Whereas in case of volume ventilation, the ventilator delivers a constant preset tidal volume with each ventilator breath. So from last 3 or 4 decades, the clinicians were using time cycle pressure limited ventilation because of the two reasons in neonatal ventilation. So first reason is that previously it was thought that it is the barotrauma that is most important determinant of lung injury. And hence, if you keep a control over the pressure, then the risk of barotrauma will be less. And the second reason was that, as we all know that we ventilate the neonates with the uncuffed ET tube. So there is a leak, endotracheal tube leak, which happens. Okay. So if you're ventilating these babies with time cycle pressure limited ventilation, so these lungs can be easily ventilated using this mode of ventilation, even with a substantial leak. However, this concept was challenged by Dreyfus and his colleagues when they published a paper in this journal in the year 1988. So what they did is that they did an experiment in rodent model. So they ventilated 3 groups of rat with 3 different methods. So in first group of rat, they ventilated the rats with a high pressure and high volume. In the second group, they ventilated the rats with a low pressure and high volume. And the control group, they ventilated the rats with a high pressure and low volume. Okay, so this high pressure, low volume is achieved by strapping the chest wall and the diaphragm. And then what did they try to see? So they try to see what is the effect of these 3 different methods of ventilation on pulmonary edema and the capillary permeability. Okay, so how did they measure this? So for pulmonary edema, they measured the extravascular lung water content, which is depicted by this QWL upon birth weight. And for the capillary permeability, they estimated the dry lung weight and presence of albumin in the extravascular space. Okay, so for pulmonary edema, they measured this component, and for this increase in capillary leak or capillary permeability, they measured this component. So what did they found? So they found that the rodents or the rats who were ventilated with higher volume, with or without higher pressure, has increased risk of pulmonary edema and increased capillary permeability, indicating that there's more lung injury when these rodents were ventilated with higher volume, with or without a higher pressure. They also noted that those rodents who were ventilated with higher pressure but lower volume has got a lesser risk of lung injury, as indicated by the extent of the pulmonary edema and the capillary permeability. So to conclude, they told that volumetrauma is more dangerous as compared to barotrauma as it was thought previously. So they challenge that concept that barotrauma is not important in lung injury as compared to volumetrauma. So volumetrauma is more dangerous than barotrauma. Now coming to the differences between volume controlled and pressure controlled ventilation. So before going into this discussion, I want the attendees to remember this important formula, which is like tidal volume is equals to flow rate into either Ti or Te. So what is tidal volume? So tidal volume, as I think Dr. Mayank has taken this topic yesterday. So tidal volume is the volume of gas that is going inside during inspiration, or that is exhaled during a normal expiration. So during normal inspiration, normal expiration, the volume of gas that is going inside or coming out of the lung is the tidal volume. And this tidal volume is depicted by the flow rate into either Ti, where it is known as inspiratory tidal volume, or flow rate into T, that is known as expiratory tidal volume. So what happens in volume control ventilation? The flow rate remains constant. So this flow rate remains constant. And since the inspiratory and expiratory time is also remain constant because that is fixed by the operator, so the tidal volume that is delivered to the lungs remains constant. Okay, so you can see that if you so this one is so you can see these two graphs, one on the left, other on the right. So this lower one is showing the flow time scalar, and the upper one is showing the pressure time scalar. Okay, so if you see this flow time scalar, what is happening is that the flow rate in case of, so the left one is the volume control ventilation and right one is the pressure control ventilation. So in volume control ventilation, the flow rate is increasing slowly during the beginning of inspiration, and then it remains constant during the period of inspiration, and then it begins to come down, and ultimately there is a negative flow during expiration. Okay, so what is happening is that with the increase in flow, there is increase in pressure also, and when the flow increases to maximum, that is at the end of inspiration, the pressure also increases, and the peak pressure reaches at the end of inspiration, and then there is a fall in the pressure because of decrease in the flow, and then there is and since this is a negative flow, so there is a expiration in which only PWP is applied. So what is happening is that, so we have a constant tidal volume that is delivered to the baby, and hence the rise in the pressure will depend upon the compliance. And this rise in pressure is also like at the end of inspiration. You can see that these are like at the end of inspiration, the maximum PIP is reached. So these are actually backloaded breaths. Okay, so at the end of inspiration, you are going to get the PIP achieved. Okay, and this ventilator usually cycles when the said volume is delivered. However, if you see the pressure control ventilation, here you can see that flow is rising very abruptly at the beginning of the breath, that is causing the pressure to rise also abruptly, and the PIP is reached early during inspiration. Okay, so there's PIP reached early during inspiration, and then the PIP is maintained during the inspiratory time, and then the PIP comes down as the flow decreases. Okay, so in case of pressure control ventilation, a constant pressure is applied. Cycling happens by the time or flow depending upon the mode of ventilation. So if it is like assist control or SIMV, so cycling will happen by time. And if it is like a pressure support ventilation, the cycling will happen by flow. And the volume will depend upon the compliance. Okay, so pressure is constant, so volume will depend upon the compliance. So this slide is also showing the same concept that I discussed in the previous slide. So you can see that, so this left one is showing the scalar waveform. This is pressure time, volume time, and flow time for pressure control ventilation, and similarly for the volume control ventilation. So you can see that in pressure control ventilation, the flow rate is high during the beginning of the breath, that leads to early achievement of the PIP, and then the flow rate decreases in a descending ramp that leads to maintenance of the PIP during the inspiratory time, and then there is a negative flow which is marked by the expiration. Okay. And in case of volume control ventilation, again you can see that the flow rate is like the flow waveform is like a square waveform. There's a gradual rise, then the flow rate remains constant for some time, and then there is a decrease in the flow. That leads to the pressure time curve being uh, being looking like a backloaded breath. So the PIP is achieved at the end of inspiration. So if you focus on this pressure time curve, so you can, so as we know that the area under the pressure time curve indicates the mean airway pressure. Okay. So if you see the area of this pressure time curve, so there's a mean airway pressure. So you can make out that the mean airway pressure in a pressure control ventilation is higher as compared to that of volume control ventilation. So this you have to remember, the mean airway pressure in pressure control ventilation is higher as compared to the volume control ventilation. And in volume control ventilation, the ventilated breaths are actually backloaded as compared to front loaded in case of pressure control ventilation. Okay, so let's now try to understand this concept further. So this is showing the PV loop in volume control as compared to pressure control ventilation in a baby with RDS before and after application of surfactant. So the left-hand side, you can see the PV loop in volume control ventilation, and right-hand side, you can see the PV loop in pressure control ventilation. So on x-axis, this is the pressure, and y-axis is the volume. So this loop that is showing in the red color is showing the PV loop before application of surfactant in both this pressure and volume control ventilation, and this green and blue loop is actually showing the a PV loop post surfactant. So what we can see is that, so in volume control ventilation, as I've said, that the volume is kept constant. So there is a constant volume that is delivered. So what happens is that as the compliance of the lung is improving, so there is a decrease in the pressure automatically. So what does it indicate? There is a auto weaning. There's a real-time weaning of the pressure as the compliance improves, keeping the tidal volume constant. However, what is happening in pressure control ventilation? So here the pressure is kept constant. As you have read, the pressure is kept constant in pressure control ventilation. And with the improvement in the lung compliance, there is increase in the volume. You can see the tidal volume increases with the improvement in the lung compliance post surfactant. Okay. So if you are not decreasing the pressure post surfactant, what will happen? So the baby will get up more tidal volume. So there is more risk of volutrauma. Okay. So here the operator, the person who is, or the clinician who is operating the baby on pressure control ventilation has to manually reduce the pressure so that the tidal volume that is delivered post surfactant matches that of the physiological tidal volume. However, in case of volume control ventilation, the weaning of the pressure is like automatic. Okay. So to conclude, in volume control ventilation, there's a constant tidal volume irrespective of the compliance, whereas in pressure control ventilation, the tidal volume varies with change in compliance, and hence one has to reduce the pressure post surfactant so that the tidal volume that is delivered to the lung matches that of the physiological needs. So coming to the pros and cons of pressure control and volume control ventilation. So as I've said, in pressure control ventilation, the flow was maximum during the initial phase of the inspiration. So that will lead to early achievement of the PIP. So there's a high initial flow that will lead to decreased work of breathing. And since, as I've said, the mean airway pressure in pressure control ventilation is higher, so what will happen? The lungs will be exposed to a higher pressure throughout the inspiration. So that will lead to better gas distribution. And since the operator is controlling the pressure, so there is a decreased risk of barotrauma. So what is the disadvantage of pressure control ventilation? So as I've said, the tidal volume is variable and that depends upon the compliance as well as the difference between the PIP and PWP. So there is a risk of volutrauma, particularly when the compliance of the lung improves and if the operator is not reducing the PIP. So pressure weaning is operator dependent. There is no auto weaning as we have seen in the volume control ventilation. And sometimes there can be increased work of breathing if you are like decreasing the PIP too much, so that the delivered tidal volume actually comes down below the physiological need of the baby. So if you reduce the PIP too much, the tidal volume that will be delivered to the baby, particularly whenever you are weaning the baby from pressure control ventilation, if you reduce the PIP too much, the tidal volume that is delivered to the baby may come down below the physiological needs and there can be increased work of breathing. So what are the advantages of volume control ventilation? So there is an auto weaning of pressure with the improvement in compliance, which we have seen. And since we are controlling the tidal volume as well as the respiratory rates, particularly in case of patient triggered ventilation, like in case of SIMV ventilation or in assist control ventilation, since we are controlling both the rate as well as the tidal volume, so there is lesser fluctuation in minute ventilation in the PCO2, and obviously there decreases for volume trauma because we are actually keeping the volume constant. So what are the disadvantages of volume control ventilation? So sometimes when there is when the compliance of the lungs decreases too much, so the baby can end up in getting too much of pressure, so that can lead to increased risk of barotrauma. And since we have seen in the flow time curve in volume control ventilation that the flow increases gradually during the beginning of the breath, so if the baby requires more flow, so he will not get that flow, so that may lead to flow starvation and increased work of breathing. And as we have seen that in case of volume control ventilation, it is more backloaded breath. The maximum pressure is delivered, the PIP is delivered to the baby just before the termination of inspiration. So there's a gradual increase in pressure. So this can lead to poor lung recruitment, particularly in babies with severe RDS. Now the question comes, why there is increasing interest of using volume ventilation in newborn? So if you go back some 3 decades back, so the previous volume control ventilators, the flow sensor was actually inbuilt within the machine itself. So flow sensor was like distal. It was within the machine itself. And this machine, what happens is that it injects the tidal volume into the circuit, which is measured by the flow sensor. However, what happens is that this gas which is injected into the circuit will undergo some amount of compression in the circuit, as well as within the humidifier, as well as these circuits are compliant. They are like distensible circuit. Okay, so the volume of tidal volume uh, that is going into the baby's lung is very, very less, and it is very difficult to measure by these flow sensors. Additionally, as we know that the newborns are ventilated with uncurved ET tubes, so there are a lot of leak around the ET tube. So what will happen? That will further accentuate difficulty to estimate the tidal volume that goes into the baby's lung. Okay, so these ventilators actually failed to ventilate neonatal lungs. So sometimes some 2-3 decades later, the scientists came up with this model in which they have shifted this flow sensor from this distal end to this proximal end. So now they have placed this flow sensor in the Y piece, like where the circuit and the ET adapter gets connected. So they put this flow sensor at the level of Y piece. So what will happen? So by placing the flow sensor in the Y piece, so they can actually measure the tidal volume that is going inside the lung. Okay. So they can also estimate the leak around the ET tube. How? So by measuring the difference between the inspiratory tidal volume and the expiratory tidal volume, they can make out the amount of leak that is happening at the level of ET tube also. Okay, and since these flow sensors are measuring the tidal volume at the level of the patient, so they eliminate the need to adjust for volume loss in circuit. So whenever these previous ventilators were in use, in which the flow sensors were like within the machine, sometimes the like clinician used to give a tidal volume like 10 to 12 ml per kg. Okay, so they give very high tidal volume, so that the tidal volume that is delivered to the baby comes at somewhere like 4 to 6 ml per kg, overcoming this compression of gases in the circuit humidifier as well as the circuit compliance. Whereas in the present the volume control ventilation, this problem has been eliminated because of placement of the flow sensor close to the patient end. Now the question comes as which tidal volume you want to measure, whether inspiratory tidal volume or the expiratory tidal volume. Okay, so let us now try to understand this concept using this 2 lung model. So suppose this is a lung model of a baby who is like 1 kilo of birth weight. So in this case, the tidal volume that is going inside the endotracheal tube will be like 6 ml. Okay. Now this 6 ml tidal volume is going inside the lung, but what is happening is that because of endotracheal tube leak, 2 ml of tidal volume get lost, and ultimately 4 ml of tidal volume comes inside the baby's lung. So what happens during expiration? If you see the right hand side figure, so whenever this 4 ml of tidal volume is getting exhaled, so about 1 ml of tidal volume is getting lost because of endotracheal tube leak, and only 3 ml of tidal volume is exhaled and detected by the flow sensor. So here you have to understand two very important concepts. So first concept is that why the tidal volume is higher during inspiration as compared to expiration. So the answer to this is that during inspiration, the pressure that is driving the endotracheal tube leak is like the difference between the PIP and the PWP. So it's a much higher pressure. Okay, so the airway is exposed to PIP. So that's a very high pressure. So the difference between the PIP and PWP is the pressure that is driving the endotracheal tube leak. Whereas in case of expiration, these airways are subject to just PWP. Okay, so the pressure that is exposed to the airway is less. So the pressure that is guiding the endotracheal tube leak will also be less. Hence, the volume of leak during expiration is lesser as compared to the inspiration. Now, the second concept, what you have to understand in this figure is that, so if you see the tidal volume that is going inside the lung, and compare it with the inspiratory and the expiratory tidal volume, so you can see that it is closely matching with the expiratory tidal volume. Okay. So in nutshell, so you have to, the expiratory tidal volume is the one that closely matches with the tidal volume that is being delivered to the baby's lung, however, with some caveats, obviously. So as the amount of leak increases, so this relation also goes up. So here you can see that the endotracheal tube leak is almost like 50%. Okay, so 6 ml is going and 3 ml is coming out. So almost 50% of leak is happening through the endotracheal tube leak. So as the amount of leak increases, so this correlation will also go off. And as the amount of leak decreases, this correlation will actually increase. So expiratory tidal volume is the one that closely matches with the tidal volume that is going inside the baby's lung. Okay, so now coming to now moving forward. So as we have seen that the volume control ventilation which are available are actually not preferred volume ventilation mode because of the limitation which I have enlisted, because of the flow sensors, because of the endotracheal tube leak, and because of the compression of gases in circuit and the compliance of the circuit. So the preferred mode nowadays to ventilate is the volume targeted ventilation. So let us now try to understand what is this all about. So this is a hybrid mode of ventilation. So volume targeted ventilation is basically a pressure control ventilation in which the microprocessor delivers the set tidal volume by varying the inspiratory pressure. So how this happens? So it happens through a dual loop mechanism. So what are these two dual loop? What are these two loops? So in one loop, the machine tries to see machine actually tries to see what is the difference between the delivered tidal volume and the set tidal volume for a previous breath. So for the previous breath, it will try to see what is the difference between the set tidal volume and the delivered tidal volume. So based upon this difference, the microprocessor will make adjustment of either inspiratory pressure or time to deliver the set tidal volume. Okay, so what is happening? I'm again going to repeat. So the microprocessor tries to see what is the difference between the set tidal volume and the delivered tidal volume, and based upon these two analysis, the microprocessor will make subsequent adjustment in the next breaths in inspiratory pressure or time, so that the tidal volume that is delivered in the next breath matches that of the set tidal volume. So obviously, for optimal functioning of this mode of ventilation, you require a optimal functioning flow sensor. So this is the basic principle behind volume targeted ventilation. So the mechanical ventilator gives a test inflation with a particular PIP, and then it try to measure the tidal volume that is provided to the baby. Okay. So by measuring the tidal volume delivered to the baby, it compares it with the target tidal volume of the previous breath. Okay. So if the target tidal volume delivered is less as compared to the if the delivered tidal volume is less as compared to target tidal volume, so it will increase the inflation pressure in the subsequent breaths, so that the next breaths are given with a higher inflation pressure and hence higher tidal volume, so that the delivered tidal volume matches that of the set tidal volume. However, if the delivered tidal volume is equals to the set tidal volume, so the ventilator will ventilate the lungs with the same inflation pressure. Okay. And if the delivered tidal volume is more as compared to set tidal volume, the ventilator will decrease the working pressure in subsequent breaths, so that the delivered tidal volume matches that of the set tidal volume. So volume targeted ventilation includes many different types. So most common type is like the volume guarantee, which is present in majority of the ventilators like Draeger Bablock 8000 plus and VN500 Accutronics, etc. Then we apply pressure regulated volume control, then volume assured pressure support, volume support ventilation, and other modes of ventilation like targeted minute ventilation and proportional assist ventilation, which are mostly nowadays used in case of adult patient. They are only limited data in newborn use. So don't get bogged up with these terminologies, because these are the different terminologies, but the principle remains same. So the ventilator will measure the uh, exhaled tidal volume of the previous breath, then it will compare with the set tidal volume, and the set tidal, and if the delivered tidal volume is less as compared to the set tidal volume, okay, so it will increase the working pressure in the subsequent breath, so that the delivered tidal volume matches that of set tidal volume, and henceforth. So coming to the volume guarantee, so this volume guarantee modes of ventilation needs to be combined preferably with the assist control or pressure support ventilation, because in both of these modes of ventilation, all the breaths are actually volume guaranteed. So that will lead to more uniform delivery of the tidal volume. It will decrease the work of breathing. It will improve the oxygenation as well as ventilation. However, in case of SIMV, if you combine SIMV with BG, so only SIMV breaths will be volume controlled. Okay. And as we know that if the baby's respiratory effort or the baby's spontaneous respiration is more as compared to SIMV rate, so few breaths will not be volume guaranteed. So that will lead to increased work of breathing. So obviously in SIMV mode of ventilation, we require a more higher tidal volume as compared to assist control or pressure support ventilation. So the physician sets the tidal volume as we discussed. The physician does not set the PIP, but he only set the maximum pressure. Okay, and this working pressure actually fluctuates around this maximum pressure, and other parameters like PWP, rate, TI, depending on the mode of ventilation, FI2, are set as that of the pressure control ventilation. So let us try to understand the working principle of a volume control ventilation, volume guarantee ventilation. Okay, so in volume guarantee ventilation, the clinician sets two things. So first is the target tidal volume, and second is the pressure limit. Okay. So what happens is that the ventilator initially gives a test breath. So suppose this is a test breath. Okay. So it gives a test breath, and then it try to see what is the tidal volume that is delivered. So suppose the tidal volume that is delivered to the baby is lesser as compared to target tidal volume. So what will happen is that the ventilator will increase the working pressure. So you can see the working pressure is increased as compared to this baseline working, as compared to this as compared to the PIP delivered in the target breath. So working pressure is increased so that the next few breaths are delivered at a somewhat higher pressure, so that the tidal volume that is delivered to the baby matches that of the set tidal volume. Okay. So remember that this increase in the working pressure is not abrupt over the next breath. It is like gradual, and it is delivered over the next 3 to 5 breaths. Okay. However, if you find that if the tidal volume of the previous breath exceeds the target tidal volume, the ventilator will reduce the working pressure so that the next breath is provided with the tidal volume that matches that of the set tidal volume. Okay. So this working pressure is actually variable, and it is trying to catch up the tidal volume. Okay, so you can see that the working pressure is also variable, and the tidal volume is also variable throughout the period of ventilation. Okay, so there are two safety features that are there in volume guarantee ventilation. So first safety feature is the pressure limit. So this is the maximum limit up to which the working pressure can be increased. So typically it is set at around 20 to 30% above the average working pressure required to deliver the tidal volume. And this pressure limit needs to be changed during the course of ventilation, so that this closed loop mechanism of ventilation remains intact. The second safety feature that is there in volume guarantee ventilation is that if the delivered tidal volume exceeds 130% of the target tidal volume, it means if the ET leak is like more than 30 to 40%, and the ventilator, if required to deliver the deliver the tidal volume, that is 130% of the target tidal volume, then the flow will cut off abruptly. Okay, so that the working pressure will not increase. So these are the two safety mechanisms that are there in the volume guarantee ventilation. So it will not work when the leak is exceeding 30 to 40%, and as well as the working pressure cannot increase beyond the pressure limit. So what are the pros and cons of volume guarantee ventilation? So as we have seen that in volume guarantee ventilation, the tidal volume is like variable throughout the ventilation. So it's actually physiological pattern, okay? Because it has been shown that if you deliver a constant tidal volume to the lungs, that may lead to atelectasis. Whereas if you are delivering a variable tidal volume to lung, so this risk of atelectasis is less. Similarly, if we have seen that the working pressure is continuously adjusting, it is trying to catch up the target tidal volume. So this mode of ventilation is better as compared to pressure control ventilation. Why? Because the tidal volume is like variable. Okay, so it is not, it will, so there is a variable. So it will not increase the risk of barotrauma, which can happen in case of pressure control ventilation. Also, it is a better mode of ventilation as compared to volume control ventilation because the tidal volume is also like varying. So this VG is a better mode of ventilation as compared to pressure control ventilation and volume control ventilation. And obviously auto weaning will happen as the baby's lung compliance will improve. What are the disadvantages of volume guarantee ventilation? So there are excessive fluctuation in tidal volume and the PIP. So you will never find that the baby that the breath that is delivered to the baby matches the set tidal volume. So you'll never find. So there will always be a fluctuation in the tidal volume, the PIP. So a better mode of ventilation will be one which can calculate the compliance of the lung, and then it should deliver the set tidal volume with the lowest pressure. So this will be the best. This will be the much finer forms of ventilation as compared to volume guarantee ventilation. And as I have said that this mode of ventilation will not work, particularly when the ET leak is too high, which is seen particularly in babies, preterm babies who are on prolonged mechanical ventilation, where there is a tracheomegaly and ET leak increases, as well as in babies with BPD. So next coming to the other modes of volume targeted ventilation. So it is the PRVC or pressure regulated volume control ventilation. So here what happens is that, so in the upper figure, you can see there's a pressure time curve, and the lower one is the volume type curve. So what happens is that the ventilator initially gives a test breath. As we have seen in the volume guarantee ventilation, the ventilator will give a test breath that is about 10 centimeter higher than the PWP. Okay. So it will give a test breath that is 10 centimeter higher above the PWP, and then it will try to see what is the tidal volume that is delivered. So based upon these two information, it will calculate the compliance. Okay, the compliance will be calculated by microprocessor, and based upon the calculated compliance and the set tidal volume, it will calculate the lowest PIP that is required to deliver the tidal volume. Okay, so after calculating this lowest PIP, the ventilator will deliver next 3 breaths at 75% of the lowest PIP value. Okay, so deliver the next 3 breaths at the 75% lowest PIP value, and then it will try to see what is the tidal volume that is delivered. Okay, so if the tidal volume delivered is lesser as compared to target tidal volume, which we can see. So this is a target tidal volume, and these are the tidal volume that is delivered during the next 3 breaths at 75% of the lowest PIP. So it will increase the PIP by 3 centimeter of water for next breaths, so that the tidal volume that is delivered matches that of the set tidal volume. However, if this increased PIP leads to delivery of the tidal volume that is higher than set tidal volume, so the machine will decrease the PIP by 3 centimeter of water for each breath. Okay, so this is how this PRVC mode of ventilation works. So it's a better mode of ventilation as compared to volume guarantee, because the machine is calculating the compliance, and it is also calculating the lowest PIP required to deliver the tidal volume. However, similar to volume guarantee ventilation, the working pressure is like constantly catching up the tidal volume, and the working pressure is easily regulated between the PWP and 5 centimeter of water below the pressure limit. So it's somewhat better form of volume guarantee than volume guarantee ventilation. So coming to the next form of volume targeted ventilation, that is volume assured pressure support ventilation, also known as VAPS. So it is a type, so as the terminology says, it is a pressure support ventilation, and it blends the volume control ventilation. So it's a blend of pressure support ventilation and the volume control ventilation. So if you see the figures on the left hand side, so the breath begins as a flow cycle. So you can see that it begins as a PSV breath with flow cycling. So what happens is that the ventilator tries to measure the tidal volume that is delivered in a particular breath when the flow rate reduces to almost like 15 to 25% of the peak flow rate. Okay, so when the flow rate, so you can see that the flow rate is increasing, and when this flow rate is getting reduced and reaches to 15 to 25% of the peak flow rate, it will see what tidal volume has been delivered for that breath. Okay, so if the tidal volume delivered during that breath matches the target tidal volume, so it will be continued as a PSV breath. Okay. However, if you see the curve on the right hand side, so here again it is measuring the tidal volume that is delivered when the peak flow rate reaches 25% or 15-25% of the peak flow rate. So it sees that the tidal volume delivered during that breath does not matches the target tidal volume. So what happens is that, so this ventilator will automatically switch this mode of this breath into a volume targeted breath, and it will prolong the inspiratory time so that the tidal volume delivered for a particular breath matches that of the target tidal volume. Okay, so it is still much refined form of ventilation as compared to PRVC and VG, because here adjustment is happening in a particular breath itself and not over the subsequent breaths. Okay, so guaranteed tidal volume is delivered with each breath. And as I've said, the set tidal volume is reached, so it will continue as a PSV breath. However, the set tidal volume is not reached, the breath changes to volume control breath and TI is increased to the tidal volume is delivered. So remember that this mode of ventilation will only work in babies who are spontaneously breathing. So next, coming to the volume support ventilation, again it's a mode of volume targeted ventilation which works in babies who are spontaneously breathing. So here what happens is that the baby will have complete control over the rate and the TI, but the machine will guarantee the minute ventilation. Will guarantee the minute ventilation. How it will guarantee the minute ventilation? So it will guarantee the minute ventilation by adjusting the pressure support either up or down depending on the lung compliance to deliver the preset tidal volume. So again, it's auto winning mode of ventilation, and it should not be used in babies who lack spontaneous respiratory effort. So next, coming to the NAVA. So in NAVA it's a more refined form of ventilation, and it is also being used in babies who has spontaneous effort and should not be babies who lack who are like apneic or does not have a spontaneous respiratory effort. So how does it work? So in NAVA, the sensor actually measures the electrical activity of the diaphragm to control the trigger and cycle inflation. So for beginning of the breath and cycling, that is switching from inspiration to expiration, the sensor uses the electrical activity of the diaphragm. And how does this electrical activity of the diaphragm is measured? So this is measured by placing a esophageal electrode mounted on a feeding tube, and this esophageal electrode is placed close to the crux of the diaphragm. And then the machine will deliver the PIP based upon the NAVA level multiplied by this electrical active diaphragm plus PWP. So what is this NAVA level? So this is also known as proportionality factor of the NAVA gain. So this is set by the clinician, and if you multiply this NAVA level and with the with the electrical active diaphragm and combine with the PWP, you will get the PIP. So this is how this microprocessor works. So the unit of this NAVA level is like pressure per microvolt of the electrical activity. So now coming to the evidence for volume targeted ventilation. So whether the evidence is sufficient so that we can switch on our practice of ventilating these babies from pressure control to volume targeted ventilation. So if you see the Cochrane review, so there's a recent Cochrane review that is published in the year 2017. So it has included 20 studies in which there are 16 RCTs and 4 crossover studies. And they have compared all kinds of volume control ventilation with that of pressure limit ventilation among newborns of all gestational age up to 44 weeks of post-menstrual age. So what did they found? So the Cochrane review found that if you're using volume targeted ventilation as compared to pressure limited ventilation, there is 27% reduction in the combined risk of death or BPD. So although the reduction in death was not significant, but it leads to almost 32% reduction in the risk of BPD, and that is significant. Okay. Volume targeted ventilation also leads to reduction in the duration of mechanical ventilation by almost 1.35 days as compared to pressure limited ventilation. It also reduces the risk of pneumothorax by almost 50% as compared to pressure limited ventilation. Volume targeted ventilation also leads to significant reduction in the risk of hypocarbia and severe grades of IVH as well as PVL. Okay, so there is a very strong evidence to suggest that volume targeted ventilation excels as compared to pressure limited ventilation. So let's now see some of the practical aspects of volume guarantee ventilation, which is the most common type of volume targeted ventilation in clinical use. So when to start this volume targeted ventilation? So ideally, this volume targeted ventilation should be started as soon as feasible in intubated newborn. So preferentially it should be started in the delivery room. However, because of logistic reasons, it cannot be given in the delivery room. So at most you should be starting these babies on volume guarantee ventilation whenever these babies come to your NICU and you have the ventilators that has got volume guarantee mode of ventilation. So when not to use, so as I've said, when the ET leak exceeds 30 to 40%, then it should not be used, because in those cases, the delivered tidal volume will exceed 130% of the target tidal volume, and the flow will like abruptly cut and the working pressure will not increase. However, in some certain newer form of ventilators, like in VN 500, they have leak compensation mechanism till 75 to 80% also. So volume ventilation should not be used during surfactant administration, because that can block the flow sensor. And as we have discussed that optimally functional flow sensor is the crux for a volume ventilation. And it also should not be used in babies with severe metabolic acidosis, because those babies will be hyperventilating. They will have a very high minute ventilation, and hence the ventilator will not be able to perform volume targeting, because the minute ventilation is changing very rapidly. So coming to settings, so we have to set the tidal volume. So that will depend upon the infant size. So it is actually varying inversely to the infant size. So smaller the baby, higher the tidal volume needs to be set. It is because of the fact that there is a proportionately increased fixed dead space of the flow sensor. Okay, so if you see the ratio of the dead space contributed by the flow sensor with that of the baby's body weight. So as the baby's body weight decreases, the contribution of dead space by the flow sensor will increase. So for that, the tidal volume needs to be increased for babies having lower birth weight as compared to babies having a higher birth weight. It also varies based upon the lung condition, because as I have said, that with prolonged ventilation, for like ventilation for more than 2 to 3 weeks, there is increased risk of ET leak, and hence you have to increase the delivered tidal volume. It also changes based upon the postnatal age, because as the weight increases, you have to increase the tidal volume accordingly. Then mode of ventilation, as you discussed, that in SIMB mode of ventilation, you require a more higher tidal volume, set higher more tidal volume as compared in case of assist control or pressure support ventilation. So you have to start classically with a tidal volume of 4 to 6 ml per kg. But remember that don't set tidal volume exceeding 8 ml per kg, because that will lead to volume trauma. And don't set a tidal volume below 3.5 ml per kg, because that is non-physiological. Remember that if the duration of ventilation is more than 2 to 3 weeks, so you have to account for the endotracheal tube leak. So you have to set a higher tidal volume of like 5 to 8 ml per kg. And then you have to set the pressure limit that we have seen in the when we were discussing like how does the volume guarantee mode of ventilation operate. So you have to set a pressure limit so that the working PIP fluctuates around this pressure limit. So typically the pressure limit is initially set at 3 to 5 centimeter of water above working PIP. However, during the course of ventilation, when you get to know what is the working PIP, then you can set the pressure limit almost like 20 to 30% of the above the working PIP. You have to set the PWP, then rate and TI depending on mode of ventilation. Like in case of SIMB, you have to set this rate and TI. However, it is not required in case of PSV or assist control ventilation. Then you have to set the low VT alarm. So typically the low VT alarm or low tidal volume alarm is set at less than 90% of the desired tidal volume. So coming to troubleshooting, the most important troubleshooting is the alarm for low VT alarms. It's a very problematic and can create a lot of noise in the NICU. So you have to remember that there are some correctable causes which leads to these low VT alarms, like if there is a worsening ET leak. So remember that whenever you are doing a volume targeted ventilation, the endotracheal tube size that is put in a baby should be of optimal size based upon weight or gestation. Otherwise, if there is too much of ET leak, then VG will not work and you will get a lot of alarms. Then you have to see for the ET kinking. You have to see whether there is some abdominal pathology that is pushing the diaphragm upward, and that is like increasing the that is like requiring a higher working pressure to deliver the tidal volume. So if you decompress the stomach, then this low BT alarm itself will go off. And then you have to see for the air leaks, so to rule out air leaks. And sometimes endotracheal tube slipping into the right main bronchus can also lead to a low BT alarm. And at the end, if all of these things has been ruled out and there's a worsening lung mechanics, then you have to increase the pressure limit so that the working pressure increases and this low VT alarm goes off. The second troubleshooting is that ventilator is not generating any PIP. So what could be the reason? So reason could be like tube disconnection, the tube has come out, or if the target tidal volume is much lower as compared to the physiological need of the baby. The third troubleshooting is like ventilator is generating a low PIP and a low or absent VT. So what does it indicate? Indicates a complete ET block. Sometimes you can find that the baby is if you do a blood gas, you find that there is a persistent low PCO2. So this could be because of the baby may be hyperventilating because of metabolic acidosis, pain or agitation. And sometimes you can also find the babies on VT may have a tachypnea, increased work of breathing. So again, you have to see whether the set tidal volume matches that of the physiological needs. And obviously you have to rule out agitation, metabolic acidosis and pain. So coming to weaning, so as we have seen that the pressure auto weans as the compliance improve, you don't have to reduce the pressure, so it will auto wean. However, in case of if you're ventilating these babies on SIMV-BG, you have to wean the rate, and that is not required in case of assist control of PSV because in those ventilation, which I think Dr. Uma must have discussed yesterday, that that the baby actually decides the rate and hence there is auto weaning of the rate. Okay, so try not to wean off the target tidal volume. However, if you find that if the baby is like ventilating on a tidal volume of 4 to 6 ml per kg, and if the settings are minimal like rate of 20 to 30 and PIP of 5, so you can consider to decrease the tidal volume by 3.5 ml to 3.5 ml per kg, but please don't go below it and try to extubate the baby. Whenever the baby is like on a working pressure of like 12 to less than 12 to 15 with a tidal volume of 46 ml per kg, PWP of 5 and FR2 of less than 25 to 30%. So to conclude, in volume guarantee ventilation, there is a decreased fluctuation of the tidal volume and minute ventilation that will lead to improved gas exchange, mean by more stable PCO2 and avoidance of hypo and hypercarbia. And that will lead to avoidance of the organ injury, like the decreased risk of cerebral injury because of hypo or hypercarbia, the decreased risk of PVL and IVH, decreased risk of lung injury because you're actually targeting the volume, which is the main culprit of lung injury, and ultimately you're avoiding the SIRS response. Thank you for patient listening. If there any question, I'm happy to take.
Yeah, Dr. Tapas, it was a very elaborative presentation on different volume and hybrid modes of ventilator.
Thank you, sir.
And thank you for that. Uh, just few points that each ventilator has its own sort of hybrid mode of ventilation. So they have their own algorithm setup. If you are using Traeger, you have a different name. If